Neurotic disorders are a group of mental health conditions characterized by distressing symptoms without loss of touch with reality. There is no psychosis. These disorders largely manifest as excessive anxiety, fear, or obsessive behavior. They are very common in the population. Anxiety disorders alone affect about 40 million adults in the US, around 19% of the population, each year, meaning EMTs and paramedics will frequently encounter patients suffering from these conditions. While not psychotic or inherently life threatening, neurotic disorders can cause significant impairment and very real physical symptoms due to the body's fight or flight stress response. As first responders, it's important to understand these conditions, recognize their presentations, and provide compassionate care. The major neurotic disorders we'll discuss include several anxiety related conditions and somatic symptom disorders. Key types are generalized anxiety disorder, chronic, pervasive worry about everyday life events without a specific trigger, panic disorder, recurrent panic attacks, sudden episodes of intense terror and physical symptoms, chest pain, pounding heart, shortness of breath, dizziness. Panic attacks typically peak within 10 minutes and resolve within minutes to an hour. They often occur without warning or clear cause and are commonly mistaken for heart attacks due to the severe physical symptoms. Phobias or intense, irrational fears of specific objects or situations, like snakes, heights, flying. The fear is far out of proportion to any actual danger. Patients with phobias will go to great lengths to avoid their triggers, and just anticipating the feared object can provoke panic. Importantly, many recognize their fear is irrational, but still feel powerless to control it. Obsessive compulsive disorder, OCD, characterized by unwanted intrusive thoughts, obsessions, and repetitive behaviors, compulsions, performed to relieve anxiety. For example, a contamination obsession might lead to compulsive hand washing. Even though the person knows the behavior is excessive or illogical, they feel unable to stop due to intense anxiety. Somatic symptom disorders, conditions where psychological distress manifests as physical symptoms. The patient experiences real physical symptoms, pain, fatigue, neurological symptoms, etc., that lack a medical explanation. They often are excessively worried about their health or symptoms. Examples include somatic symptom disorder, illness anxiety disorder, and conversion disorder, which we'll discuss. These disorders often overlap in presentation, and a patient may have more than one. Next, we'll examine each category in more detail, including how they present and what EMS professionals should know in the field. Generalized anxiety disorder involves a persistent baseline of anxiety. The patient worries for no particular reason or about everything: health, family, work, minor matters, even when there's no sign of trouble. This excessive worry occurs on most days for at least 6 months and is difficult for the patient to control. Clinical features include a constant feeling of apprehension or dread, being on edge, and trouble concentrating due to worry. Physically, chronic anxiety causes muscle tension, headaches, irritability, and sleep problems. The person may appear restless, fidgety, or fatigued from poor sleep. Common triggers. Unlike phobias, generalized anxiety disorder isn't tied to one specific trigger. Rather, routine life circumstances can all become sources of worry: finances, relationships, health, etc. Even no particular reason is needed. Patients often wake up anxious without knowing why. Stressful events or difficulties can exacerbate it, but the anxiety often persists even during otherwise calm times. Course. Generalized anxiety disorder tends to be a chronic condition that waxes and wanes. Symptoms might be mild at times and worse during stress. Many patients develop generalized anxiety disorder in adolescence or early adulthood, but it can begin at any age. Without treatment, it can continue for years. Patients may seek medical help for physical complaints like insomnia or GI issues, not realizing anxiety is the root cause. Field considerations. When caring for a patient with generalized anxiety disorder, remain calm and reassuring. Identify yourself confidently and listen attentively to their concerns. Often they just need to be heard. Allow them to talk about their feelings. Gentle, steady communication can help ground someone with generalized anxiety disorder during an EMS encounter. There is usually no single fix you can do on scene aside from calming reassurance. Ensure that any medical complaints, chest pain, shortness of breath, etc., are evaluated properly. Sometimes generalized anxiety disorder patients do have real medical issues too. But if vitals are normal and the patient admits they're feeling very anxious, your calm presence and patience is the most therapeutic intervention. Panic disorder is marked by sudden, intense panic attacks. A panic attack is a terrifying episode of acute fear that often peaks within 10 minutes. The patient is overwhelmed by a sense of impending doom or fear of dying, accompanied by dramatic body symptoms: racing heart, chest pain, shortness of breath, sweating, trembling, dizziness, nausea, etc. They may truly believe they are having a heart attack or other life threatening emergency. In fact, many people experiencing their first panic attack go to the ER convinced they are in grave medical danger. Common signs and course of a panic attack: rapid onset of fear, often begins suddenly, out of the blue, though sometimes triggered by a stressful event or phobia. There may be no warning. Severe physical symptoms. Patients can present with hyperventilation, palpitations, chest tightness, choking sensation, lightheadedness, tingling in extremities, hot or cold flashes, and intense terror. These symptoms usually peak within minutes. The patient might say, "I feel like I'm going to die." Short duration. Most panic attacks last 10 to 30 minutes, with the worst of it in the first 10 minutes, and then symptoms subside gradually. Some residual anxiety or exhaustion can last longer, but the peak panic is brief. Fear of recurrence. After an attack, patients often worry intensely about having another. This can lead to avoidance behaviors, not going to places where an attack occurred, not going out alone, etc., and in some cases can develop into agoraphobia, fear of leaving home or being in crowds due to fear of panic in those situations. Triggers. Panic attacks can happen unexpectedly, but common triggers include acute stress, traumatic memories, certain phobias, like someone with a claustrophobia may panic in an elevator, or even physical changes, like a sudden dizzy spell can trigger panic in someone who fears it. Stimulants, caffeine, drugs, or medical conditions like hyperthyroidism can precipitate panic attacks as well, but panic disorder is diagnosed when medical causes are ruled out and attacks occur recurrently. EMS perspective. When treating a suspected panic attack, remember that real medical emergencies can mimic panic and vice versa. Always treat medical possibilities first. For example, chest pain and shortness of breath should prompt checks for cardiac issues, pulmonary embolism, etc., especially if risk factors are present. Once life threatening causes are reasonably excluded, gentle reassurance that "I know this feels awful, but you are not in physical danger" can help. Explain to the patient that these symptoms are consistent with a panic attack. Give the symptoms a name as a way to validate what they're feeling and reduce fear. Panic attacks in the field often improve with time and calm coaching. Separate the patient from panicky bystanders or stressful environments if possible. Create a calm, safe setting. Encourage slow, deep breathing. Many EMS professionals will monitor vital signs. Showing the patient their oxygen level or heart rhythm can reassure them nothing dire is happening internally. Never dismiss the episode as just anxiety in a condescending way. To the patient, it is extremely frightening and real. Instead, show empathy. "I know you feel like something is terribly wrong. Many people feel this way during a panic attack, but I will stay with you and keep you safe until it passes." Most importantly, do not simply assume it's panic without assessment. As we'll emphasize, rule out medical issues because panic disorder is a diagnosis of exclusion in EMS. Phobias are intense, irrational fears of specific things or situations. The fear is out of proportion to the actual threat. For example, seeing a small spider causes a person to experience overwhelming terror, even though logically they know it can't really harm them significantly. Common specific phobias include fears of animals, snakes, spiders, dogs, heights, flying, enclosed spaces, claustrophobia, blood or needles, and thunderstorms. But they can be about virtually anything. There is also social phobia, social anxiety disorder, fear of social situations and being judged or embarrassed. Clinical features: when confronted with, or sometimes even just thinking about, the phobic stimulus, the person experiences acute anxiety or a panic attack. They may freeze, scream, or run away. Physical symptoms mirror panic: heart pounding, shaking, shortness of breath, etc. Importantly, people with phobias often recognize their fear is irrational or excessive, especially adults. For instance, someone with a fear of flying might intellectually know that flying is statistically safe, but they cannot control the dread that floods them when boarding a plane. This insight can actually lead to frustration or shame, making them reluctant to admit their phobia. Behavioral impact: phobias lead to avoidance behaviors. The person will go to great lengths to avoid their triggers, like refusing needed medical care due to needle phobia, or avoiding driving over bridges, or not going to the basement because of spiders. In extreme cases, this avoidance interferes with daily life, unable to work certain jobs, travel, or partake in activities. Course: specific phobias often begin in childhood. A bad experience like a dog bite can instill a lifelong phobia of dogs, or adolescence. Many persist into adulthood if not treated. They can be long lasting without treatment. Some people manage by simply avoiding triggers, but if unavoidable triggers come up, they may have repeated distress. The good news is phobias are very treatable with therapy, such as gradual exposure therapy, though that's outside EMS scope. EMS considerations: usually, EMS won't be directly called for a phobia alone, but phobias can become part of an emergency. For example, a person with needle phobia might have extreme anxiety during an IV start or injection. They could hyperventilate or even faint. Knowing this, EMTs should be prepared to handle a phobic reaction by explaining each step of a procedure calmly before doing it, using numbing spray if available for IVs, having the patient take slow breaths, etc. Involving the patient, let me tell you what I'm doing. You can look away and breathe, it'll be quick. Can help. Someone with claustrophobia trapped in a small space, elevator MRI machine, may panic and require rescue or sedation. Rescuers should recognize the fear is driving the vital sign changes and behavior. Animal phobias or others could cause secondary trauma, like someone running away from a harmless dog might dart into traffic and get injured. In managing a phobic patient, reassurance and clear communication are key. Do not belittle the fear. Oh, come on, the snake is in a cage, it can't hurt you. Instead, acknowledge that their fear feels very real to them. If possible, remove the trigger, get the feared object out of sight, or remove the patient from the trigger. If the patient must face it, like they need an injection, guide them through relaxation techniques and try to complete the procedure swiftly and smoothly. A phobic reaction can escalate to a full panic attack, so essentially treat it like you would a panic situation. Calm, compassionate coaching. Obsessive compulsive disorder is a unique anxiety related disorder defined by obsessions and compulsions. Obsessions are intrusive, unwanted thoughts, images, or urges that cause intense anxiety. Common examples: persistent fear of contamination, germs, dirt, intrusive thoughts about hurting someone even though the person doesn't want to, excessive doubts like, did I turn the stove off? Repeated worries, or distressing inappropriate thoughts. The person usually recognizes these thoughts are irrational, but feels unable to stop them. They often try to suppress or ignore the obsession, which only increases anxiety. Compulsions are repetitive behaviors or mental acts that the person feels driven to perform to reduce the anxiety from obsessions. Common compulsions include excessive cleaning or hand washing to neutralize contamination fears, checking locks or appliances over and over, counting or arranging items in a precise way, or repeating certain phrases or prayers internally. Performing the compulsion temporarily relieves anxiety, but soon the obsessive thought returns and the cycle repeats. For example, an individual might have an obsession that their hands are covered in deadly germs after touching a doorknob. This causes intense fear and disgust. To relieve it, they wash their hands over and over, sometimes for minutes or even hours, until they feel safe. They might scrub so much that their skin becomes raw. OCD hand washing can cause dermatitis from excessive cleaning. Another person might be about to leave home, but is seized by an obsession that the stove might be on and the house could burn down, even if they know they turned it off. This leads to a compulsion of checking the stove 10, 20, 30 times before they can leave. Of course, OCD often begins in adolescence or early adulthood, sometimes as early as childhood. It can wax and wane, but typically is chronic if untreated. Stress can worsen obsessions and compulsions. Many people with OCD hide their symptoms for years out of embarrassment, which can delay diagnosis. Without treatment, severe OCD can be disabling, consuming hours of a person's day, and significantly impacting their daily function. Neurobiology: OCD is thought to involve dysfunction in certain brain circuits and an imbalance in neurotransmitters like serotonin. It also has a genetic component. Having a close family member with OCD significantly increases one's risk. EMS considerations. Typically, OCD is not an emergency unless it leads to extreme anxiety or complications. However, EMS might encounter a patient with OCD who is in crisis because they cannot complete a ritual and are panic stricken. A person with OCD who refuses to leave a safe zone, like their home, despite needing medical care due to their obsessions, like fear of germs outside. This can complicate a transport. In such cases, try to accommodate small requests that might ease their anxiety. If a person fears contamination, assure them the ambulance is clean, offer them a mask or gloves if it makes them comfortable, etc. Patients whose compulsions lead to injury, for example, compulsive skin picking causing bleeding, or exhaustion or dehydration from endless rituals. When dealing with someone who appears obsessively focused on something, like needing to repeatedly check or clean, do not directly challenge their need in an aggressive way. Stop doing that, you're fine. Instead, gently redirect if possible or allow a limited version of their compulsion if it calms them, as long as it doesn't delay critical care. For instance, if someone insists on checking their door lock one more time before leaving for the hospital, it may be worth the minute to let them do it so that they can settle their mind. Use clear, simple explanations and patience. If time is of the essence, medical emergency, you may have to firmly but kindly say, I know this is very hard for you, but we have to go now for your safety. We will make sure everything is okay. Having family or someone the patient trusts assist can help. They might trust that person to perform the check or ritual for them. In summary, OCD in the field is about understanding that the person's behavior is driven by anxiety. Empathy and mild accommodation, when feasible, will build trust and lead to better cooperation with treatment. We will wrap up this part of the lecture here and continue our discussions about neurotic disorders in the next part. See you then.